me start by welcoming you, Dr. Maski. Thank you for your time today. It's always a pleasure to have some time with you. I'd love just to jump in and give our audience a little bit of context about what is a normal working week? What does it look like for you?
Yeah, no, things have really changed for us. Fortunately, we were able to transition our in-person clinic visits to telehealth very quickly in our state and in our institution. So we're doing clinic visits by either Zoom or an in-house platform called Virtual Visit. And, we're learning. I won't say that they're perfect. Sometimes the call gets dropped and we have to call the patient by phone, but it is going actually quite well. And for narcolepsy patients in specific, it's very helpful to have a check-in. A lot of prior authorizations, they still come through and you have to show efficacy, no side effects. So it's very helpful to have a documented visit, even if it's telehealth.
Right.
And, the limitations are that we don't get vital signs like blood pressure monitoring and things like that. In cases where we're very worried, we do ask the family to go to a local, whether it's a pharmacy or someplace, they can get blood pressures recorded and then sent to us. So we're managing.
Okay.
And then inpatient-wise, fortunately, COVID's not as common in children, so we've not been seeing the same volume as adult patients.
So in terms of your narcolepsy outpatient clinics, would you say that you're seeing the same amount of patients, just that everything's shifted to a digital platform?
Yeah, that's really the goal. I still see the same number of patients. We're even seeing new patients in this type of context, and it's very helpful just to keep things moving.
What do you feel like the limitations of the telehealth perspective is, particularly for families with narcolepsy?
Yeah, I mean, I think if you can't do telehealth where you're not able to actually see a patient, it can be hard to do it by phone. To get a good sense of, how sleepy someone is, how they respond, their nonverbal, facial reactions to what a parent might say, all can be very helpful, and engaging them in the care is easier when you can actually see them. So yeah, I think the telehealth portals are very helpful for that. But, it's less efficient in the sense that you can't do a neurologic exam for a new patient. You want to rule out other conditions. And like I said, vital signs aren't available. So things like blood pressure monitoring with traditional stimulants are limited.
Okay. Is it possible to carry out any sleep studies at this point?
Yeah, currently we're only doing urgent sleep studies. That's been primarily just inpatients for our lab. We may start opening that up, once we're past our surge, but right now indeterminate.
Now, you said that thankfully there aren't too many children affected with COVID. Have you seen any where you are?
I was involved in 2 cases. I'm a consultant in our ICU for neurology, and both cases were sort of indirectly. One was a positive COVID case, another was a baby whose mother was positive and was delivered. We haven't seen any clear neurologic symptoms related to COVID yet.
Thankfully, you've not also seen any children with narcolepsy with COVID. If that were to happen, would you anticipate any specific kind of complications?
Yeah, it's hard to know. I think one of the things that we're seeing in COVID that seems to be really unique is this very profound immune response. And that's what oftentimes is contributing to a sepsis-like picture and this acute reactive airway disease and infiltrates that we're seeing on the chest CTs. So it's unknown whether anyone with an autoimmune response would be different in patients with narcolepsy. It's really unclear, actually, but no reason to suspect that they would be in any way worse or better than anyone else.
And in terms of medication, if there was a mild case at home and parents felt they could manage their children with, say, more typical like flu symptoms, how would you anticipate their medication working out? Is there any kind of advice you could give families that might be helpful?
Yeah, I mean, I think that we've been getting a lot of calls about cough and cold preparations that patients are prescribed, and I would encourage people to talk to their physician before using those medications. Medications that are sedating really should not be combined with medications such as Xyrem. So in those cases, a parent may wish to give the cough and cold preparation that's sedating and avoid giving Xyrem on those particular nights. We don't think that, cataplexy comes back very quickly. It can take a bit of time, on the order of weeks. So not giving it for a couple of days wouldn't be anticipated to cause major problems. And then many medications that are taken during the day have pseudoephedrine in it. And that combined with traditional stimulants could make someone feel more anxious, have heart palpitations, rapid heart rate. So I think, just making sure that the medications are run by a physician is prudent.
Mm-hmm. Right. In terms of a fever and say a drug like Xyrem overnight, when you're really concerned, the child's very hot and you're trying to pull their temperature down, what role does Xyrem have? Like if we wanted to use, say, Tylenol, something very mundane?
Yeah, I don't think that there's any no indication for not using Tylenol or ibuprofen with Xyrem. I think the only concern is sedating medications. And again, if a parent's concerned that their child already is overly sedated from other medications or is not normal, they should just avoid giving Xyrem
Right.
at all.
Right, that wouldn't hurt for a few nights anyway. Now, I know normally when you're working in your pediatric clinic looking after children with narcolepsy, you have a very holistic approach, not just the very kind of hardline clinical side, but the kind of psychosocial impact. With this isolation and quarantine, do you anticipate any particular issues that might be more exacerbated, more amplified in children with narcolepsy?
Yeah, I think that's a great question. I mean, I think actually in our patient visits, we're finding that they're actually doing quite well because they're sleeping more at night. They're able to keep a nap schedule that they otherwise would not be able to. So in many ways, our patients are doing better. But, I think the older kids who have classroom, requirements to be on Zoom calls for long periods of time, that can be really hard. I mean, Zoom is not the same as being in a classroom. And, that social interaction that you get or that anticipation of discussion or that interest level may not be there.
Right.
When you're not face to face. And so it is harder to stay awake in that type of setting.
Now, I know that you work with Dr. Zhao, and he provides some psychological support to your patients. Where would you see yourself having to refer more children at this point for psychological services?
Yeah, I mean, I think that, with the current state of things, the uncertainty, the lack of social contact, obsessive compulsive tendencies can get worse with sort of the focus on hand hygiene and whatnot. So I would anticipate that things like, again, obsessive compulsive disorder, anxiety, depression could get worse during this time or even develop. So that's something to be mindful of. And we are, seeing patients for those purposes. As you've mentioned, we're fortunate to have a cognitive behavior therapist who also does telehealth at our center. So that's been helpful. But in some cases, yes, we have been starting patients on medications, which we hope will only be for a short period of time to counter depression or anxiety.
Right, so that's the clinical side, but you're also a researcher. How has COVID affected you professionally, not just in the clinical setting, but as a narcolepsy researcher?
Yeah, great. So we were running a study looking at disrupted nighttime sleep and how that affects memory and emotional processes in children. And that was a study that we were doing in our sleep laboratory, so that had to stop. But this has allowed us time to go back and review our data and do additional analyses. So we're fortunate in that respect. And then we've shifted our focus to doing studies that are survey-based, that are electronically survey-based. And we have one study that has been a focus of using online focus groups. And so that's been really interesting, and our recruitment for that has been great because people are really interested, they're available, and they're engaged during the process.
Right. So in terms of the pediatric study, looking at how to gauge potential narcolepsy symptoms in schools, where are you at with that particular project?
Yeah, that's a big project for us because of that alarming statistic that, patients can be symptomatic for up to 10 years before a diagnosis. And for a child, that's like, their childhood. So that has been a big focus for us. We are currently working with other sites to validate a questionnaire that allows us to screen for pediatric narcolepsy and idiopathic hypersomnia symptoms, with the idea that if a patient scores highly, patient or a student, we're hoping this survey would be available in the community for parents, school providers, as well as primary care providers to access. That if they score highly on this, they could be directed more clearly to a sleep provider or someone who has expertise in narcolepsy for further testing, and bypass that multiple, various referrals for sleepiness and inappropriate testing and exposure to medications that aren't necessary.
Yeah. Do you see now that there might be a delay in some of this research because of COVID?
I think so. I think we're actually, validating the questionnaire electronically. So if people on your podcast or your members are interested, they can go to the website and we just send them an informed consent link electronically, and then the surveys are electronically. So we hope this research can continue through this period. And I see this as very useful actually now, especially if a patient comes forward with new symptoms, a way of assessing their symptoms in a quick manner using a survey can really help, I think, prioritize their diagnostic testing once the restrictions are lifted.
Yeah, that's really interesting. So, because I think it's, natural for us to be concerned that COVID is going to slow some things up. But as you say, these children that are particularly sleepy have maybe more opportunity at home to take naps, and for parents to be more observant. We'll certainly post the link to that survey. Dr. Maski, what's next for you in terms of research? Because you're one of those people that never stops. There's never a break in what you're doing, what you're trying to develop.
Yeah, so we're continuing our project looking at the cognitive effects of disrupted nighttime sleep. So we recently collaborated with Dr. Plazzi's lab in Bologna, Italy, and I worked with a researcher, Dr. Fabio Pisa, looking at how do we actually define disrupted nighttime sleep in children. It's a condition that is really a symptom of narcolepsy, where sleep is very fragmented by wakeful periods, but we really don't have the right term to describe, that sleep pattern. So we looked at, what are various ways of assessing that sleep pattern, and found that, a certain transition pattern is very supportive of a diagnosis of narcolepsy. And so that means that in combination with an early sleep onset REM period could be diagnostic of narcolepsy just using a polysomnogram alone. You wouldn't need the multiple sleep latency test. So the next question is, now that we know how to measure disrupted nighttime sleep, what's the effect of it on daytime functioning? And I think what I've heard from parents and patients is the cognitive aspects of narcolepsy are really difficult to manage and probably understudied. So we're now looking at how that disrupted sleep actually affects things like memory function and cognitive assessments.
So like concentration,
Yeah,
attention, is that?
specifically looking at memory and attention in our testing, as
Mhm.
well as emotional.
Right. Right, because I think certainly from a parent's point of view, I wonder whether some of our children with narcolepsy have been misdiagnosed or in fact have like attention deficit disorder. Does this study kind of seek to like differentiate between the two?
That's a good question. No, I don't think it really can. But what we're looking at whether the sleep patterns are more associated with this kind of profile of attention problems and even hyperactivity during the day. But we don't have a comparator group of, say, children with attention deficit disorder.
Mm-hmm. Wow. And you mentioned something called transition patterns. What does that mean?
So basically looking at how many times a patient goes from sleep to wake or sleep to a lighter stage of sleep that we refer to as non-REM stage 1 sleep. So this is like, when you wake up or you go into a lighter stage of sleep, we consider that sort of non-restorative periods. And as it turns out, patients with narcolepsy have these transitions to this either wake or light sleep very frequently during the night. But it's very brief. They usually return back to sleep very quickly. So it's to me very different than, say, insomnia, where people wake up and then they have long periods of wakefulness. They can't return back to sleep. And we really don't know what effect that disrupted nighttime sleep has on patients. Again, their cognition, their mood, but as well as their degree of daytime sleepiness.
And presumably, if you're looking at cognitive function, then that's potentially impactful in the classroom and their academic performance.
Yes, exactly. And I think, we as clinicians have focused on treating sort of daytime sleepiness, and, we may be missing sort of a big part of the symptomology of their sleep if it is related.
Okay. Are there any particular medications forthcoming, say in the next 3 to 8 years, that you're particularly excited about for children with narcolepsy?
Yeah, I think, with the approval of medications like pitolisant and Sunosi, these are new options for patients who are 18 and above. But I think even my pediatric patients are just simply excited to have more options once they get to adulthood. I mean, for the longest time, there really were very few. And then I think the orexin agonists are very exciting. I mean, that offers, really an opportunity to be as normal as possible. And I think that's very exciting, obviously, and probably the closest thing to a cure that we're going to get for a while.
Right. Can we just stop there for a moment and talk about Sunosi very briefly, because it's certainly a term that we hear a lot, but not necessarily fully understand its mechanism. Could you explain that to us, Dr. Maski?
Yeah, so Sunosi is a norepinephrine and dopamine reuptake inhibitor. So it works similar to traditional stimulants, but not exactly the same. And the benefit of it is that it produces wakefulness for longer periods of time. Its half-life, for instance, is longer than many of the traditional stimulants. And so I think that in itself, based off the clinical trials, which were done in adults, really showed a pretty significant effect in the ability to remain awake during the day for patients with narcolepsy.
Does it have any of the same side effects that people might experience with traditional stims?
Yeah, it did seem to have similar side effects in terms of elevation of heart rate, milder elevations in blood pressure, milder changes in mood. The problem with comparing to traditional stimulants is that we actually don't have great studies that have looked at traditional stimulant effects, surprisingly, in pediatric narcolepsy. And when companies do these studies, they're comparing it to placebo, basically like a sugar pill. And so it's hard to make comparisons directly.
And how does Sunosi compare to pitolisant?
Well, there are different mechanisms. Pitolisant functionally increases histamine levels in the brain. So we all, know antihistamine makes you drowsy. Increasing histamine in the brain actually can improve alertness, and histamine acts on many of these other pathways that are involved in alertness as well as cataplexy. So it's a really novel mechanism. And I think the side effect profile is lower than traditional stimulants in terms of those things like its effect on heart rate, blood pressure, mood, and such. So that's exciting. And I think parents who have concerns about their children being on controlled substances such as traditional stimulants, this is a non-controlled substance. And so it's not been approved for children with narcolepsy. There is currently a pediatric narcolepsy trial in Europe underway, but I think very promising.
Hopefully sooner rather than later. And then my last question around the orexin antagonist, because as you say, I think there's a lot of eyes on that. And for our children, as you rightly pointed out, with the delayed diagnosis and the impact of their symptoms, that is their whole childhood. What can they look forward to as adults if they were able to access the orexin antagonist?
Yeah, so it's orexin agonist, meaning that it improves. But I think that it really, in my mind, would be a game changer, because it would be a single medication that's really targeting the specific chemical loss that they have, the loss of orexin. And so instead of taking one medication for sleepiness and another for cataplexy and another for XYZ, this really would be helpful as a single agent. And but there's many things we don't know. I mean, being not having orexin for so long and then having your brain flooded with it, is that going to produce any problems? If you're on orexin agonists, is that going to impact sleep? Are they not going to be able to sleep or develop insomnia as a result? So there's many unanswered questions. But I think based off of the initial reports, the sustained wakefulness is very impressive.
Okay, it's really exciting and something to hope for. And I think during these times of, fear and uncertainty, especially at the moment going forward, then this has been a very, very helpful conversation with you, Dr. Maski. So thank you so much for your time.
Oh, thank you. It was a pleasure.